Welcome everybody to the Research Knowledge and Skill Builders for the month of March. Today we have the Socio-demographic Data Working Group, which includes Jen, Lawson, Don, Elston, and myself. And we'll be presenting about the socio-demographic data collection, current evidence and practice in primary care research. And I'll let Jen take over from here.
Thank you, Neha. Okay. Oh dear, am I going to have another problem? Hopefully not. Okay. Yes, so I am going to be presenting on behalf of the working group that we formed. As Neha mentioned, the topic of the presentation is socio-demographic data collection, current evidence and practice in primary care research. Okay. So the objectives of this RKSB session will be to introduce the concepts around socio-demographic data collection and use for primary care research. We'll be describing the process and findings of our environmental scan to explore this topic. We're going to share the knowledge and resources with an aim of developing guiding principles for DFM to follow. Finally, we're going to discuss local experiences and ideas in socio-demographic data collection for DFM research. So socio-demographic data needs to be leveraged in order to access and address health equity, and that's particularly poignant for primary care's mandate. The current context of socio-demographic data recognizes that researchers have long advocating for race-based and socio-demographic data collection to understand and address health inequities. COVID-19 pandemic, as we all know, has pushed this priority further ahead, and we're seeing a fervor of activity as government, health organizations, standards groups, academics, and community organizations are all actively looking for and developing solutions. Many of you are familiar with social determinants of health as their impact on the health of Canadians is very well documented. Few organizations routinely collect SDH, however, and related interventions by way of electronic health records. And there's no common SDH terminology or implementation guidance in place to ensure the data are encoded consistently and with the same meaning across systems. Further, the intersectionality of these factors creates unique social experiences and further influences health equity and is therefore warranted for investigation. Race, ethnicity, and Indigenous data are critical to the identification and monitoring of inequalities that stem from racism, bias, and discrimination. They're needed to inform health equity interventions and delve into access, quality, experience, and outcomes. These data have limited collection in the healthcare sector, and where they exist, their variation precludes robust comparisons. Other issues related to the collection and use of socio-demographic data include lack of community benefit when the data fails to lead to action, as well as concerns over inappropriate use of data that can deepen inequities, issues of privacy and security and consent, and finally, lack of ownership in data access. Racialized and marginalized populations state that they feel left out of the data governance conversation. So to summarize, several issues around socio-demographic data need addressing in parallel. In the face of a call to action for equitable delivery of healthcare, there continues to be a lack of consensus on how to operationalize data collection and a lack of interoperable systems in the sharing of these data. There's also a call to carefully consider why we ask, what we ask, how we ask, and how the data will be used. So before proceeding much further, I should mention some key concepts. Data governance is the policy relating to the overall administration of the data, whereas data stewardship is the active management of the data processes that meet this policy. And data standardization is achieved with agreed upon terms, codes, processes toward meaningful data. The mandate of the Socio-demographic Data Working Group was to explore with an environmental scan current socio-demographic data collection practices relevant to primary care research. We also aim to recommend guiding principles for the collection of socio-demographic information based on best evidence and practice. The methodology applied looked for evidence and practical information relevant to primary care research. We explored this topic via several modes, including literature search, interviews, meetings, which included the full scope of DFM, McMaster, activity in the GTA in Hamilton, provincial, national, and even certain global resources. Lens that we considered included data collection for various research designs, clinical and administrative data, as well as the advancement of large data repositories such as ICES and the National Primary Care Database, SIPSN, and the provincial version, which is known as Poplar. We started this journey in the spring of 2021, and through multiple cycles at inquiry, we have amassed considerable resources that can inform DFM research and can be organized through the following domains of global, global, here's my animation, Canadian, Ontario, Hamilton, McMaster, community consultants, and academia. Hold on to your hats as we take you on a high-level tour of what may be considered the key resources that can inform current socio-demographic data collection practices relevant to primary care research. So there are a variety of different projects and activities set on the global stage that support the socio-demographic data imperatives. I will just point to a couple here. The Gravity project out of the US is a data standards project that I will describe in more detail in the next slide. In the UK, the Department of Health and Social Care has just released this paper, and in it they're communicating a strong set of commitments on digital transformation, leveraging data in health and care sectors toward better patient health, decision-making, and support for providers. In Finland, they're taking the stance of educating their citizens on data and the benefits of AI toward building awareness and social license for data collection and use. Gravity project in the US is immense. It's a collaborative for consensus-based data standards to improve use and sharing on social determinants of health. The project formally launched in 2019 and has engaged a plethora of stakeholders from across patients, providers, payers, standard organizations, vendors, and community groups. By consensus, the project goal is to develop standards to support SDOH, data exchange within healthcare and across other sectors. And the scope of the data spans patient care, population health, public health, clinical research, and tries to achieve value-based care. The Gravity project has considered a myriad of challenges to the capture of SDOH and exchange, including the consent process for individuals, standardization of data collection and its storage, data sharing agreements across the learning health system, which necessitates interoperability, the questionable readiness and infrastructure of the health and social sector organizations to even participate in this work. And the Gravity project also underscores the supreme need to keep patient and communities at the focus of all their work. With limited time, I'm simply going to point you to the Confluence repository for the Gravity project shown here. And later in the presentation, I'm going to point you to a presentation by Sarah De Silva, which really unpacks this robust project. So shifting to Canada. Canada has very noteworthy work in the data equity and social determinants of health arena. In the next slides, I will unpack some of the work across these organizations, many of which will probably be familiar to you. To begin, the Canadian Community Health Survey is well known to many. It's a cross-sectional survey for health surveillance and population health research, and it's issued yearly. That are used by analysts in various sectors to monitor, plan, implement, and evaluate programs to raise awareness and improve the health of Canadians. Several socio-demographic data domains are included in the survey, as highlighted here. And in the absence of other standards, these questions and preset answers often form the template on which other research is based. However, the ethnic, racial, and Indigenous categories have been named as inadequate for some. So moving along, the Canadian Institute of Health Information is a leading advocate for the creation and management of health equity data and its analysis. CIHI has worked steadily on the race-based and Indigenous data collection and has just released this guidance report. It sets out the minimum data standards to support harmonized, high-quality, race-based, and Indigenous identity data in healthcare. Implementing the standard is meant to facilitate monitoring, comparable analysis, and reporting on data on the healthcare access, quality, and experience and outcomes across racialized groups. These standards align with Statistics Canada, Census, and other surveys and other data sources. Advancements in the collection of ethnic and racial data includes appropriate preambles to the questions being asked, as seen in this top left-hand corner, and changes to some of the racialized categories have also been introduced. As well, CIHI's Measuring Inequalities Toolkit is a very resource-dense guide that covers the gamut from planning your research, the analysis and reporting for health inequities. I will also point you to a link to a presentation by Julie Stratton of CIHI that unpacks this guide in considerable detail. CHIMA is the Canadian Health Information Management Association. Dr. Francis Lau is founder of the UVic School of Health Information Science. And Dr. Lau is a partner of CHIMA and regularly posts blogs covering the latest Canadian work on improvements to the definition, collection, and use of SDOH in EHRs. He identifies promising work across health organizations, academia, and standards initiatives in Canada and the United States. And in his latest post, he highlights the formation of the Canadian SDOH working group to examine these issues in the Canadian digital health system. And he's also posted presentations from May 2021 by 3 practice leaders. And these provide excellent foundational and up-to-date information on the topic. Another noteworthy entity in the Canadian landscape, and with respect to socio-demographic data collection, is the Pan-Canadian Health Data Strategy. The certain dearth and disconnectedness of healthcare and social data is being tackled with strategies for creation, exchange, and use across health and public health systems, data governance and stewardship practices, and accountability, sovereignty, and protection of privacy are all embedded in this strategy. The PCHDS has released 2 reports, this one charting a path toward ambition, which is in which the mantra for a common vision is described with concepts of social license, data policy, accountability alliances, and interoperability. Their second report furthers the agenda with details of building Canada's health data foundation. And now we're going to shift to the best practices and guidelines conveyed by provincial authorities on socio-demographic data collection and use. In these next slides, I'm going to cover data considerations related to the provincial COVID response, Ontario Health, and their equity and diversity frameworks and digital standards, as well as ICES, and which I think you all know has prescribed entity status. And I'm also going to share several initiatives operating in the Toronto region. Okay. My mouse stopped working. Okay. So early in the COVID-19 pandemic, the increased risk of infection for marginalized and racialized communities became clear, and many advocates and experts noted that socio-demographic data collection in health organizations and public health units, not otherwise legislated for collection, would be needed to track populations most impacted by the pandemic. So with this call, the provincial government proposed a regulatory change as a reporting mandate, with COVID-19 patients being asked about their race, income, languages spoken, and household size. Ontario Health also released their Digital Health Information Exchange Standard, and that aims to improve the interoperability with meaningful exchange of health information as a critical precursor to the building of the learning health system. Toward the health equity, inclusion, and diversity challenge, the Corpus Sanchez consultant report identified 4 foundational and 7 key areas to frame the Ontario Health Equity Framework. Here is a pictorial of this framework. And this work was informed by engagement from many health system stakeholders and community organizations from across the province. Among its key building blocks are this systematic collection of equity data supported with automated processes and standardized data sets to collect, analyze, and report information. Ontario Health is expected to release a key minimum data set of equity elements that will be collected with electronic health records and centrally managed. And linkage with other data sets will fuel the capacity to inform decisions about appropriate programs and services and allocation of resources to reduce the disparities in the workplace and healthcare service delivery at large. ICES is also working toward optimizing socio-demographic data for research, and they've partnered with the Tamarack Institute and the Digital Justice Lab to see community input on how race and ethnicity data should be used for health data research in Ontario toward creating a race and ethnicity data framework. So what we should know, that is work in SDOH in Ontario actually began over a decade ago with the Tri-Hospital and Toronto Public Health team engaged in the Health Equity Data Collection Research Project. With this report titled "We Ask Because We Care," published in 2013, several key findings came out. One of the key ones was that when asked questions, patients were not opposed to answering them if it was explained that the data would be used to close the gap on service. The project was influential to both Kai and Dr. Andrew Pinto and the upstream lab work. Here are a set of the questions that were first introduced in this project. Give you a moment to scan these. And the Because We Care project actually evolved over several years and now takes the form of the Toronto Health Equity Project. This continues to support health equity data collection, producing guides and tools and considerable support to those engaging in this work. Group also posts publicly available tools, and for instance, this one is a guide to healthcare organizations explaining the process of planning and implementing socio-demographic data collection. And some primary care organizations that were part of the Because We Care initiative had continued to garner influence from the Toronto Equity Project and really are ahead of the curve on this socio-demographic data collection front. For example, the Alliance for Healthier Communities, who are composed of primary care health centers and Aboriginal health centers, are really front runners. They employ 8 standard socio-demographic questions that they ask their patients at the time of intake or during periodic data blitzes to collect this data. These data contribute to their organizational evaluation framework. And what's interesting, I think, is that the CHC health data is encoded with nomenclature, say that fast, known as ENCODE FM. And this system includes comprehensive codes for gender, sexual health, health issues of Indigenous peoples in terms for socio-demographic, social determinants of health, as well as health risk. Furthermore, the Alliance is aiming to have 75% completion of their socio-demographic data profiles by 2024. And with their matured data set of socio-demographic data, the Alliance is able to leverage it to identify racialized populations and link them to equity interventions. Here's an example of some of that work. So shifting a bit to Toronto. Toronto is the host to prominent health equity and social determinants of health researchers, including Dr. Andrew Pinto, who founded the Upstream Lab in 2016, as well as Dr. Buzeri, who leads the Gatasso Center for Social Medicine and Innovation. The Upstream Lab has multiple overlapping and synergistic aims of integrating health and social care, population health management, and proactive care for learning health systems. Socio-demographic data has been studied in the context of creating data collection tools for uptake in multicultural primary care communities. Intense community engagement directs their work toward effective solutions, and several studies and reports have informed their progress. The SPARK study developed and tested a tool for routinely collecting socio-demographic data in primary care, as well as guidelines for community engagement and implementation of these initiatives. The SPARK tool features 14 questions, and it is currently being validated in 5 Canadian provinces with a CIHR grant. The outcomes of this study include a national standard for socio-demographic data collection, implementation guidelines, as well as guidelines for engaging patients and communities in this work, And finally, an RCT on that studies the most effective way to address poverty at point of care will be included in their outcomes. One other CIHR study to note is the Strobe Equity Project led by Dr. Welsh. The project aims to develop a reporting guideline on health equity in observational studies using an evidence and consensus-driven integrated knowledge translation process. This will extend the well-known Strobe tool, which stands for Strengthening Reporting of Observational Studies in Epidemiology. And the project is novel in that it's co-producing knowledge with Indigenous people, people in low and middle income countries, and socially excluded people with diverse stakeholders, including patients, public, researchers, and decision makers. So throughout our environmental scan, we came to recognize that there are several important, what I'm trying to say is recognize the importance of several consultative organizations that have partnered with healthcare and the public health sector to foster community engagement, project implementation, and solutions that otherwise contribute to successful health equity projects. These include the Digital Justice Lab, the Tamarack Institute, and the Health Commons Solutions Lab. The mantra of the Health Commons Solution Lab is to create solutions and tools and then release them for public use. For example, there is a comprehensive tool package on best practice in socio-demographic data collection. The Health Commons Solution Lab have consulted and engaged in several projects, including problem solving trauma public health's gap on socio-demographic data collection during the pandemic, as well as a population health project staged in Muskoka. And they were also involved in the Black Experiences and Healthcare Symposium, which gathered Black leaders to reimagine health in the Black community and create recommendations for action. The Black Experiences in Healthcare Symposium arrived at these 10 key findings, which were punctuated with the need for race and ethnicity-based data to provide a fulsome picture of how to target and support and resource best outcomes for this community. And through several of these initiatives that I've just outlined, including those that have been trialed or simply or effectively put into practice, we have clear guidance on the implementation guidelines for socio-demographic data collection, which can be reused. These include the concept of providing education and training for staff who collect the data with clear direction on how to do this respectfully and in a way that reduces the risks and harms. This is best achieved with the staff script, as well as FAQ questions and answers. It's also recommended to provide supports and information for culturally appropriate services for patients to help manage any potential harms by collecting the data. So here I'm going to shift to our more regional view of socio-demographic data collection and talk about the health team that serves Hamilton. They have been named the Greater Hamilton Health Network, otherwise known as GHIN. We met with staff affiliated with the health equity strategy for the GHIN last fall, and we learned about the report that describes the GHIN health equity framework and a second report that details more community-specific information. The report outlines the commitment to the collection of socio-demographic data and race-based data in response to Ontario Health's call for these data collected within medical records. And so what we learned is that GIN's next steps are to establish a community data governance table to oversee and use the analysis of the data, to develop a strategy to collect disaggregated socio-demographic data and race-based data across the partners and the GIN, other GIN initiatives that include standardized data. They plan to use OCAP principles for Indigenous data and EGAD principles that I'm going to describe in the next slide. So very briefly, the OCAP are the First Nations principles of ownership, control, access, and possession. And these principles frame the call for First Nation people to have control over data collection processes and how the information is used. The EGAP framework seeks to ensure that data from Black communities is properly collected, protected, and used to promote equity, and envisions Black communities gaining control over their data. It states that the collection of race-based data should never be the end goal. It must be used to create pathways for dismantling structural racism and advancing health equity. This work is grounded in self-determination and data sovereignty that entails the right to govern data collection, management, analysis, and use. Exploration of the McMaster environment for expertise in health equity and socio-demographic data collection practices brought us first to the Equity and Inclusion Office, and more recently to what seems to be the newly formed McMaster Institute of Health Equity. Out of the Equity and Inclusion Office, the Student Census and Experience Survey collects demographic information about gender identity, sexual orientation, race, ability, and socioeconomic status, as well as the social climate survey among McMaster University students. It exemplifies how to ask questions about race, ethnicity, and Indigenous status. The EDI has also addressed the sometimes overlooked issue, including the importance of making response options, not just questions, importance of making response options and making the questions themselves more inclusive. The student census survey response options are aligned with the UN principles and recommendations for practices of race, ethnicity, and Indigenous status data. They recommend that separating race, ethnicity, and Indigenous status categories, including multiple response options, as well as another response option for self-identification, is important, and including categories for none or refuse to also be allowed. McMaster has made some other important contributions to discussion on best practice for socio-demographic data collection and use. A recent presentation from Dr. Emile Joseph brought to light that data is not immune to the injustice and inappropriate use, and these may fuel the perpetuation of injustice. Complex equity issues require the requisite analysis, and oversimplification of analyses may result in ineffective equity interventions. Finally, the equity data should only be connected with the concomitant intention and resources to implement necessary interventions and effective change. Other notable researchers, including Lana James, caution that the collection and use of socio-demographic data and its use within AI and machine learning come with certain risks for perpetuating biases and inequities in healthcare delivery. And others too have researched and promote digital justice and global rights and freedoms with work that delves into the fairness in the way that people are made visible and represented and treated as the result of the production of digital data. Another facet of the upstream lab delves into data and into big data and with their group that's called DEEP. It's the Data to Enhance and Involve Primary Care Network. And they've been working at readying, this work of the group will face the issues of digital justice related to big data and how to mitigate the AI harms and inform best practices for the future. And finally, and closer to home, we ask questions within DFM to learn about best practice or even intentions for socio-demographic data collection that could support primary care research. We discovered that socio-demographic data collection for research occurs in the absence of many guidelines. The Music Research Database, its data schema is aligned with the Simpson database and fed essentially by the Oscar EMR. There is no prominent socio-demographic data in the Oscar EMR, save for sex designation and postal code that could be used for neighborhood level analyses. However, music is a new member of the Primary Care Ontario Practice-Based Learning and Research Network, otherwise known as Poplar. And Poplar has aims to support networks in the best practice for socio-demographic data collection and use. So in summary on this rather large environmental scan, what we can state is that there's a profound need for agreed upon standards, guidelines, and policies for socio-demographic data collection in use in clinical care, population health, and primary care research. We've seen evidence of many strong initiatives, pilots, frameworks, all considering how and what to ask and how to standardly collect these data. It's definitely dynamic work. We should continue to chart the progress towards consensus and begin aligning with the front runners, which we might point to as the Upstream Lab, as well as the Alliance for Healthier Community and their models and tools for implementation. I would also recommend following Gravity and there's data standards work. Finally, the DFM research can consider regional directions from the GIN project and forthcoming direction from the Ontario Health and Minimum Data Standards from CIHI. So thank you for your attention, and I invite questions, and after a Q&A, we hope to engage in a group discussion. I'm going to post those questions at this point, but happy to take questions from the audience based on the presentation just given.
Thanks, Jen. Any questions? I don't see anything in the chat. So maybe we can start with the group discussion questions for now and see if any other questions emerge later.
Great. Yeah, so the group questions include thinking about your experience with socio-demographic data. Have you ever administered a demographic questionnaire or worked with data that didn't comply with the principles and guidelines reviewed today? What questions or data were they that were called to question? And what was wrong or limited by the question response or the data? And how would you revise the question or the response? And finally, how would you advocate for better collection and use of socio-demographic data in primary care research?
Maybe I'll start with an example of a demographic survey that I administered. So the question was, how do you identify yourself? And we had options that were both a mix of racial identifications and ethnic backgrounds. So people would get confused. I had one person who was clearly a white Canadian say that they were Native Canadian, because Native Canadian did not have any other specific categories. So they said, I was born in Canada, so I'm Native Canadian. So I think that was a big problem with that question. And if, like, I think we know better now, of course, and to specifically ask, how do you ethnically identify yourself? How do you identify your ethnic background, or how do you identify your racial background? We need to be specific that way.
I was just going to add, because I think Neha and I are both thinking of the same survey. I certainly had the same concerns about our demographic survey that Neha just described. But something that I think maybe the audience might be interested to learn was that as part of this environmental scan, we each tackled different areas. And I looked in the Faculty of Health Sciences for what guidelines or principles the people that we work with. So I approached HiREB and I approached Health Research Services, because I was thinking sort of pragmatically that either group might actually have a set of guidelines or principles that they follow when they review our applications or when they review our grant proposals. And I was a little bit surprised to learn that they don't. So I guess this speaks to the discussion we're trying to have, which is, if we don't adopt all or some of these principles, if we don't do the work, it may not get vetted outside of our department. And in a way that kind of demonstrates how some of this just gets perpetuated. It never gets corrected or revised. As our language and our thinking on this evolves, our surveys ought to. And in the absence of anybody who's giving us constructive feedback about that, we may have to figure this out for ourselves. So that is, for me, the central importance of what Jen has just unpacked for us so robustly is just how much we have to think about. So, my 2 cents.
I have one little story with when we did Tapestry, we were interviewing older adults, so people over 70, and we had a decent, demographics questionnaire. And the race ethnicity question, I was shocked at how many people that, after probing, we found out they were white or European. When asked what their race or ethnicity is, would say they do not have one. And I was like, okay, this is the take I hadn't expected. So in different population segments, it was so important to demographics couldn't just be a question on a piece of paper. It ended up being like something you had to have a conversation about, which I did not expect, or at least not in that way. But Jen, is there like a single slide with here's the recommendations, or is it, I feel like there was the one, but maybe it was from a specific place.
Yeah, I think we are still watching very actively things unfold. And I think that consensus is a real necessity. I think, you know, there's certain groups and teams that want to start this work, but I would caution them to not reinvent the wheel and to really consider the front runners on this work. So I believe the GIN is actively creating a plan, and I'm sure they've done their due diligence and are looking towards standards and previous work done. But I think consensus and standards is the way to go. You can imagine that even with respect to building surveys for prospective research in primary care, in the absence of following standard questions and common data elements, that data won't be comparable through to the large administrative databases that we're looking both behind and forward from the point of collecting data on that group for any given research initiative. So I think
so if I were to, which I am, make a demographic survey, where do I get the questions? Like, is there an answer from this presentation about of all these places, where do I go? Where do I start from?
Well, I think if it's a research that is closely tied to the clinical practice of primary care, I would think that the SPARC study questions are a really good guide. And furthermore, I've checked with prominent researchers, and they still rely on the Canadian Community Health Survey questions and answers. I feel that so much has changed in the year that we've begun looking at this, and new standards are coming out almost monthly, that following the major standards groups, CIHI, Ontario Health, and then following the work of the SPARC study and alliance groups will eventually probably come out with a more concerted, here's how you do it, and here's your data elements sort of approach. I think we're sort of in process. So to have firm recommendations as to what to do, unfortunately, couldn't be the conclusion of this environmental scan, but I think the gains made are, here's who are the front runners, and follow them closely. Does that help?
And I would just also add that before we embarked on the environmental scan, we kind of did like a pre-environmental scan where we can certainly recommend. There's a lot of overlap in the way this data is collected. So there's really only a couple of examples of race, ethnicity questions that we can point you to those, and you can kind of decide which one you prefer or which one you think works best. So there aren't that many. And in Canada, I mean, so there's some that are international. There's at least one that's a US set of questions. And then there's our Canadian CCHS, which is derived from the Canadian census. So, so it's not a long list of options that are available. And in fact, I think the principles and guidelines would probably ask or recommend more like the response options that you give are in some cases more important than the questions themselves. Obviously, separating race and ethnicity is a big one. And we haven't even talked about things like gender and sexual orientation. That's another big one right now. So I think we are in a position to share what we found and to recommend a few key resources that I think you could then make, your you'd have enough information to make the decision for your own project. At least that's how I feel. I don't know how Neha feels about that, but I certainly feel strongly enough that we've done our due diligence, that we could recommend a set of questions. And there are guiding principles, although there is a diverse array of guiding principles at the moment, yeah.
We will, I guess, just to add in, there's a very long list of resources that I will put together and post for further reading. And I'll do my best to highlight the ones that point to these key resources and these front runner organizations that are probably going to inform socio-demographic data collection into the near future.
Thank you so much, all of you, for all of the work and the presentation, which was amazing to capture the international landscape, really, which is fabulous to have. And I agree. I think from the work you've done, it's great to have you as all of you as a resource at this moment in time. And I do think we're committed to sort of tracking this topic and keeping informed about how it's developing locally and then beyond that. So I look forward to this sort of being that the beginning of that discussion, and thanks so much for pulling that all together. And Jen, so Neha's indicated where we'll find this recording, which is excellent. Jen, where will you post that? Do you think we can find a place in our shared files, shared DFM research drive for, I don't know whether I know it started with a spreadsheet anyway, in whatever format you have that you can share the resources that underpin the presentation, that would be great.
Absolutely. Yep.
Mm-hmm. Thank you.
I think unless we have any other questions, we can take 7 minutes to have a glass of water, especially Jen, have a cup of tea. And
but I guess I would just like to also close by, first of all, saying thank you to Jen for presenting on our behalf, because you did an enormous amount of work, and it really shows. But also, I really hope for the people that were able to stay that they are now convinced what a real expert we have in our midst on this topic, and that while Neha and I are here, I think you should go to Jen for all these questions.
Thank you for saying, Dawn. Yes, I'm happy to dialogue with anyone on this topic. I'm very much on my own learning journey, and it's immense. And but it's such an exciting time. There are big things happening, and we'll see them unfolding. I'm quite certain in the next short while.
Fabulous. Thank you all.
thank you.
Thanks.
Bye.
Bye-bye.
Bye.